It's not graded by tomorrow, like let's say, or afternoon, give me a couple more hours.
Okay.
And if you don't see anything, please go look at the comments, see what you can change, and then just let me know you've done it. Okay.
Perfect.
I'll
Thank
go
you.
back, grade it, and get it in for you. I mean, my goal is for you to have fun, to get the best grade you can. I mean, a 6% is a big thing. And, you know, I want you've already put a lot of work in it. So why not get the best grade you possibly can? So that's my philosophy of life, you know, do the best you can and, you know, get a chance to try to fix it. Because nobody's perfect, even
Thank you.
me. You're welcome. So we were mentioning with Kim, this Kaplan, what is the name? When you go do the math, remember, it's not what the syllabus says. I changed it to what it was last semester. They changed the name again. It's advanced math, pediatrics A. It's 10 questions, I believe. So just make sure you remediate it, 1 to 2 minutes per question. Go over it, look at it, or get up and get something to drink and come back, but do 1 to 2 minutes for questions, please. And again, I'm not going to grade them until all the Kaplans are in, so I can go through 80 students and 16 campuses and do it once, not twice, okay? Discussion question 6 is due, so make sure Wednesday you have that done. The practice exam should be open. And again, I wanted to say thank you all for, you know, being so prudent with your work. This class is the only one that didn't have a 0 on a quiz. The one that all of the case studies are turned in, project completely turned in, great responses. So I wanted to thank you. It just shows me the quality of nurses you will be when you graduate, because you're on top of things, because that's what nursing is, making sure you get your things done and in a timely fashion. Or if not, you're communicating very effectively. That's nursing. So that's, you know, why I have to thank you. So let's go ahead, let's start with this week. We're doing chapters 48, 49, musculoskeletal, neuromuscular, and I'm gonna go over some of those key diagnoses that, of course, like tetralogy, your NCLEX loves, and I'll just warn you what they are. So before you get into your NCLEX, even before the HESI, some of these, you will be able to review it quickly and, you know, have a re-understanding. So musculoskeletal, really good pictures, casting, crutches, you know, crutch safety, you learn that in foundation. That little baby, that's a hip dysplasia, and that's a Pavlik harness that will help those hip sockets go back. I'm going to discuss that. And then the one on the bottom is called a Buck's traction. We use that a lot for a fractured femur. It just pulls the leg and puts the bone back together until we can do surgery. And you can see how those weights would be hanging freely. So it's a great picture. So I just wanted to mention it. So the immobilized child, it's hard to have a child who's immobilized and can't get around, whether it's due to illness or whether it's due to congenital abnormality. Some children, you know, are not going to have some strength at all in their lower extremities. And I'm going to go over, you know, one of the diagnoses that comes to mind in, you know, this week's information. Sometimes degenerative disorders, you know, I think of one of them called osteogenesis imperfecta, where your bones are breaking and they're brittle and you have all these deformities and, you know, you're not going to be able to get around. And you're lucky if those breaks make the way that they're formed, at least you can get in a wheelchair to be able to move and to be out, especially a kid. They don't want to be stuck in bed. So we know prolonged immobility, when you're sick in the hospital, your muscles get weak. I mean, adults are just like children, children are just like adults. You know, you're going to lose, you're going to have that muscle atrophy, you're going to get that foot drop. Those muscles are going to be very weak. Same thing with kids, they're going to have to work on that after the illness. The bones, the demineralization occurs, and then whenever we think of immobility, we think of the heart and the lungs, you know, thinking of, you know, congestion in the lungs and the lungs collapsing and pulmonary emboluses and venous stasis and decubituses and edema. You know, these are all things we try to take care of, but these are things that will happen that we need to be watching out for. Now the child, let's talk about the child who's now immobilized, who can't get around, in the hospital, they're in bed. Can you imagine? They're in a room, doors closed, they can't see anything. All they have is a TV and whatever things around them. So we really, as a nurse, need to bring some sort of stimulation to them. Um, you know, in children's hospitals, it's actually really great. There's so many resources. We had this thing called Radio Lollipop, and it was on the TV, and you could call in, win prizes, and then people would go around and hand out prizes afterwards to the children, in the hospital. And it really made a difference. They knew Tuesdays and Thursdays, Radio Lollipop, call in, win a surprise, and it may be something little, but something, it was something to look forward to. There's such a feeling of helplessness, frustration, and these children will either become extremely aggressive and angry, or they will regress and go, within themselves. So just to be aware, there's things we can do. Use your resources for these kids. Now, if you have a kid, they have a family. So these family now are with these children, watching them go through these struggles of immobility. So there are groups. Now, where I worked, Nicholas Children's, they had a family parent group for every single diagnosis, whether it is the neuro floor, the cardiac floor, the respiratory floor. And it was really good how those parents would get together, talk about their problems, how they solved them, sharing their feelings of hopelessness. And it really made them feel like they weren't alone. There's somebody else doing it with them. So let's get into traumatic injuries. Traumatic injuries are injuries to soft tissues, the muscles, the ligament, the tendons. It could be they're walking, fall over and hurt themselves, chewing gum and walking they can't do, which is me. And then sports mishaps, children like to go out and play, and they are going to be hurt, and it's just part of growing up. So what are these sort of injuries? Well, contusion is a simple ecchymotic area. Be careful with that. Sometimes that ecchymosis can swell and go within the tissues and can occlude blood vessels. So always check neurovascular signs distally, because you don't know. I mean, it could look like a bruise, or it could look like a big bruise. But remember, we're worried about, that's a blood vessel that burst. So we need to look at distally what's going on. I mean, contusions could be, due to some sort of crush injury. That one would be easier to look at. But like that kid who ran into a trailer hitch, that bruise was huge, and then of course underneath it was a kidney injury, but it's looking beyond just the bruise, and oh, that's a big one. Dislocation occurs with children. The most common of dislocation is a nursemaid elbow. These are when you take your little 2, 3-year-old kids and you're swinging them around and wee, daddy, more. And it's fun, but sometimes the elbow socket pops out of joint. Their tendons, their ligaments are so tender and soft. They're not stiff and rigid yet as an older person, and they pop out of joint. And it just takes a little holding the arm, twisting it and putting it back together. Doesn't hurt, don't need sedation. In fact, once it's back in, it feels great again. Put them in a little sling, for the next day or two, and they do well. And as long as we don't keep popping it out of joint. The one diagnosis that is the most flexible of all humans are the Down's children. They can take both feet, put them over behind their head at the same time. I mean, that's flexibility. Problem. They're doing this, and because the younger children, remember, their tendons, their ligaments are soft, they're going to pop their femoral heads right out of the hip joints. And that is a dislocation. Number one, it's hard to reset, but whenever you dislocate, you disrupt blood supply. And we do not want to cause that decrease of blood supply to that femoral head. Sprains, probably the most painful things there is. I think that's even worse than a fracture. I've probably had 100 sprains in my life related to sports. I think the biggest sport that I would get sprains on is volleyball. Jump up, spike the ball, come down, and you could feel the ankle rip. and you could feel the swelling starting. It is very painful, and it's actually harder to heal than a fracture. Remember swelling, remember blood supply, and the swelling that occurs so quickly, remember we need to treat it right away. And that's will be one of the next slides. How do you do RICE, okay? Strains is when it's sort of like a sprain, but it's because you use a muscle that doesn't want to really be used and it becomes painful. And it could be due to repetition of some sort of movement. So here we are. What do we take care of? This sprain. You fell down on the court, you sprained. I used to go immediately on my back and put my foot straight up in the air because I knew it was swelling and it did help. So immediately rest it, ice it. But remember, icing does constrict blood vessels. So only 30 minutes at a time, because you're going to decrease blood supply. And then you're working to, have some necrosis of tissue. We don't want to do that. So off and on, we put the ice on it. That ACE bandage, hold it so it doesn't, completely swell. And then of course the elevation is the best. Now we've started to with sprains, instead of just putting like a simple ACE bandage on it, we're doing more immobilization. And actually bad sprains, we are putting in casts. It holds it in the same place and it actually decreases the pain. And sometimes just like a splint on it does help, but many times they're casting now. So fractures. Fractures are very common. Kids fall down, they play, they hurt, throw monkey bars in the tree, riding a bike, playing sports, and this is what happens. Now, if you are an infant, okay, you are a nurse taking care of an infant, comes in with a fractured something, be very suspicious. Now, I'm going to tell you the extreme story, okay? This is the extreme example, but it shows you infants and then the progression of what you should do. So I'm in the triage room and I get a 3-month-old baby that the mother's holding and the mom's crying. She's concerned, saying there's some swelling and discoloration behind the ear. I pick the child up to weigh it first, underneath the head and neck and underneath the buttocks, to put it on the scale to get an accurate weight in case they need medicines. My hand squishes in the skull, right where the swelling was, and my heart sank. So then I started looking all over the body, making sure all of the other, there's no swelling, did my little assessment, vital signs, and I put the child in the waiting room in a place where I could watch. I went right back to the attending physician in the emergency room, told him what my suspects were, and he told me to do an X-ray of the skull if I found a fracture, to do what we call a babygram, which is the whole body on an X-ray plate. The kid's 3 months old, it'll fit. So we did the X-ray and it was a nice big skull fracture. You could see it displaced, okay? And you could see the swelling around it. So we did a bodygram. It gets worse. A kid's 3 months old, a healing humerus, fractured ribs that were healing, and a fractured femur. Okay, the story gets better. So immediately the child's on alert. My job is not to yell at the mother. It's not to point fingers, because I wanted to beat someone up. I mean, I was like, oh my God, this poor child. Hardest thing to do in nursing is to hold your tongue. So we called the protective authorities, the DCF, the police, because it was a child abuse case. There's no other reason for this with all of these injuries. This child had a twin. We called the twin in. Same injuries. Gets better. 2-year-old boy walking around on a fractured femur. All 3 children had been abused. And it was this whole case went on. I went home at night, came back the next morning, and they're still going over everything. And they just got done with the 2-year-old, assessment and X-rays and everything. So the end of this story is it was actually the father. The father had to stay home with the children because he lost his job, and the mother was working 3-4 jobs to keep the family going. And the father got frustrated giving him a bath, and he literally picked him up and slammed him against the shower tiles, just slammed the kids. And this is what happened to them. Now, the father was taken to jail. It took him 2 days, I believe, to confess to it. And he's in jail today. And the bottom line of this is it was horrible. I still feel sick about it. It's still, I can see this poor little child. I can see this mother's face, you know, but I protected the child. My job is to protect the child. That's the bottom line. Hold your tongue, protect the child, and let the authorities do what they need to do. So there's all sorts of fractures. There's open, which means the bone is coming out. So open or compound. This is the most difficult because now you have a bone that's coming out, it's gotten dirty, chances of infections are huge. This child still needs a cast. So we're going to have to watch it with a little window. And we're also going to have to give IV antibiotics to prevent, you know, osteomyelitis. The other fractures here are just different cracks, bones through with pieces, but they're all closed. They're all within it. And then treatments are all different, whether it's casting or going to surgery, placing pins and plates, screws, whatever they need done. Now, of all of the sort of fractures children get, the one that we really have to make sure excellent medical care is done is growth plate injuries. It is at the epiphyseal plate. This is where bones grow. Now, if we don't fix them right, you know what's going to happen? You're going to have a short arm, a short leg, or you're going to have a crooked arm or a crooked leg, and we don't want that. So these are always go to surgery, and it's usually an elbow is where I've seen it the most. You know, the elbow, it hits it on the growth plate, they send them to surgery, they do an open reduction, they put the pins, the screws, they get that, you know, growth plate so perfectly placed on, and then there's not going to be any issues with growth later on in life. Now look how quick little infants heal, and then of course adolescents. Now I'm sure adults are even longer than that. So in infants, the quicker we fix something, get it in position, it's going to be 2 or 3 weeks and it's already healed. It's quite impressive. Now, you get the kid coming in, fell off the monkey bars, just a normal, let's say 3 or 4-year-old, fell off the monkey bars and broke it, what we think maybe is the wrist. So we're going to do the history from the parents usually, because it's a young child. Now, if I can, I want to get that child and ask him alone. So tell me, did you go up there, mommy said no, or were you having fun? I'm trying to find out, is it really the story that was told? Again, being safe. This is a fractured bone. You know, I'm always making sure that, you know, this child got an injury and it happens. It's okay. But again, being safe with them. Now, some children come in and they're telling you, no, I don't hurt, it's fine, but they're not walking on a leg, or they're, you know, no weight bearing or limping. And you can probably say at that time that this is probably a fracture on these children. Our goal is to get that fracture reduced, aligned, so that the function is there when it's healed and there's no deformities. Now, after we put on a cast, we are going to be checking things. Now, that arm to the right, yes, it's like the extreme drastic, but this is just here to tell you, if we're not checking neurovascular signs, we have a cast on that's getting tight, like compartmental syndrome type thing, you can cause severe necrosis to the arm. You can lose fingers or you can lose a whole arm. So we need to do what? We need to check the 6 Ps, very important. Is there pain? There shouldn't be pain, like horrible pain. Yes, it's going to hurt. It was fractured, it was placed together, but it shouldn't be extreme. Something's wrong. They're probably going to tell you there's a lot of pressure, swelling in there. Is the color good or is it pale, showing you no blood supply? Is there pulses in there? Can we feel pulses? If there's not, no blood supply again. Is there like numbness in there? Or can you not move it? All of these things, these 6 Ps are very important to check after a cast, and to teach the parents and the children about it too. So if they have any of them, get back in, they can recheck your cast. So putting casts on children is actually fun. So there is a distraction method where I use, the kid comes in scared, crying. I'm like, so if you're broken, what color cast do you want? You like red, you like blue? You know, if it's a girl, do you like, there's light pink, there's dark pink, there's red, or would you like a mixed color? And then it takes their mind off. Now they're in a hospital. They're getting excited to get a cast on them. Now, once they go home, they need to take care of it. And the biggest thing is not to get it wet. I can't tell you how many children would have a fractured wrist, get a little cast on it, go home and jump in the pool, especially here in South Florida. I had one little boy do it 3 times. The mother said, "You're not doing this again." And all I could do was not laugh with the kid there, but I was like, oh my God, this poor mother. Because coming to an emergency room where we put the cast on, it takes a process of time. It could take a couple hours. You have to get ready, get there, wait, then, get a new cast, wait your turn for the cast, and then go home. It could be 3-4 hours and sometimes more just to change that cast. And we know not to put things down inside. We could use a cool hair dryer that can help keep it elevated, keep ice on it, moving the fingers the first night. All of those things are important so the cast goes on good. And if you can see, this little doll has a cast on just like her mommy. And we do things like that because it does distract the child from the procedure we're going to do. And not all of them are fun. Now, sometimes, like the first picture I told you about a fractured femur, we can't put a cast on because we need to do a surgical intervention to fix the femur. Now, years ago, we put a Steinman pin in and just put it on a skeletal traction type thing, and it would be a month in the hospital. Well, today, we will take and put them in this Bucks traction, and that is just this boot attached to the lower leg, and it pulls with weight hanging freely on the end of the bed. And it pulls that bone that was crooked with little sharp edges that were touching muscles and nerves and pulls it straight. So it eliminates the pain and it decreases muscle spasm. And then the surgeon can do the surgery when it's best for the child, maybe a day later, 2 days later, but at least in the meantime, the bone is straight, is starting to heal correctly, and the pain has been decreased. Your job as a nurse with a child in traction, this type of traction, whether it's Russell or Bryant's or Bucks traction, make sure that weight is free hanging and never ever take it off. And once a shift, document how much pounds of weight is on that child. Of course, we're going to be checking neurovascular signs, right? Because you got a big break in the femur and there will be swelling around there. So neurovascular signs every 4 hours, and encourage them to wiggle their toes. So the purpose of it is to, remove that muscles from those spasms and it being angry because it's getting touched by all of these sharp edges. It stops that prevention of deformities and it can initiate the bone healing at that time. Now, you look at these 2 bottom pictures. The one on the left, that's a halo traction. It's little screws right into the skull. And this is used for neck injuries. Let me tell you a neck injury story. So I had a 16-year-old boy playing baseball, very good baseball player, apparently. And he slid into third base and his head and knee of the defender hit and the stands heard a crack. Now, usually the spine, cerebral spine is very straight. Well, his went angled. It's called an angulated C5, C6 fracture. He was brought in under a trauma alert. I was the primary trauma nurse on duty, so I'm in charge of that patient to make sure he gets all the care that he needs. And he already had some numbness of the right leg and tingling in the left leg. So now we are concerned about paralysis. This is C5, C6 fracture. So then after, we take and bring this child in. My priority, first priority in any trauma like that, is to keep that spine immobilized and don't let it move. Now, I'm going to continue this story when we get over to some spine injuries. But the end of it, we were able to put him in a halo traction in the ICU, sedated, and waited till the next morning to do surgery because that happened on a Sunday afternoon. So they wanted to do it Monday. It was a better environment to do it and safer for the child. You see, this other kid here has a halo traction, and that could be due to something in the cerebral spine, something that was going on there. So as I said, there's all sorts of traction. We have skeletal, which means it goes right into the bone, or it's skin. We see the Russell's traction, we see the Buck's traction, and again, we see, the halo, which is a skeletal traction. So when we have some children, you might see a shorter arm or shorter leg, and many times as a young child, because the healing is quick, etc., it's better to do it young, we will break the bone, put an external device on it, and then if it's 2 inches shorter than one leg, we will have that bone 2 inches apart. And it starts to mold, and the bone will actually grow, and that stabilization keeps that bone, separated so that those bones can grow. So we use these literally to make one leg or arm, it could be an arm too, where you see a short one and make them both then the same length. Some children are born without a limb, or I had a friend whose daughter was born without a fibula, and there's no way to replace a fibula, so they had to do a below the knee amputation. Now, let me tell you how versatile this little girl was. The first time I met her, she came over to my home, and my kids were, I think, were 9 and 11, and I think she was 5 or 6 at the time. She was chasing them around with her prosthesis, beating them up and down the stairs. I mean, she was so comfortable with herself. She was such a great child, just because she was missing a limb. As long as they have locomotion, they can get around. Kids are really happy. Now, sometimes we need to remove limbs due to some sort of trauma or some infection, and those again will get a prosthesis. And just like adults, we will be treating the pain, the phantom pain. It's still there. There doesn't mean there's not. So sports injuries, we know that sports is a lot of injuries. We know that children love to win. They love to play games. They love to be competitive. There is rough contact. There's a lot of physical demands running back and forth in the field. It takes a lot out of them. Remember, these children do need equipment, to protect themselves, whether it's helmets or shoulder pads or shin protectors or shoes, whatever, or wrist protectors. These children do need this because, they tend to work so hard, they'll get those overload injuries because they really, really want to win. Overuse syndromes, children today want to be the best that they can be. Just think about the Olympics that just went. Just think about how much practice that they have to do in order to get that good, especially those gymnastics. I can't imagine how much they train over and over the same thing. And that's that overuse thing that can happen. It can stretch ligaments. It can also rubbing of bones. It can create a lot of trauma, in the body. So this is one thing to be careful for. Now, on the first page, I also talked about that Pavlik harness and hip dysplasia. We have a hip, should be in the socket, but sometimes it's all the way up, which means that hip is up, the ball of that femur is up. That means that leg is going to be shorter. Also, when you turn them over and you look at the gluteal folds, the leg folds, one's going to be unequal. One's going to be higher, one's going to be lower. And that's why when we go to the pediatrician, the first visit, the pediatrician is taking the knees and bending them back and forth, turning them, looking at the buttocks, all to make sure that the hips are in the socket. Because if we can catch them at birth with those hips out of socket, 2 or 3 weeks, we can do some treatment maybe and get it back into position. So Again, what do you see? You see that hip joint is the laxity of it. Also, you're going to see that short limb on one side. You are going to see those gluteal folds and that positive Ortolani, positive Barlow test. You're going to hear that clicking going on there. And how do we treat it? There again is that Pavlik harness. 23 hours a day, only off for bathing. Put something underneath to protect from the rubbing on it. And this is usually for the first 6 months of life, and hopefully, it takes care of it. Most of the time it does. After that, up to about 2 years old, they might need a spica cast. I remember growing up with a girl's sister who was a spica cast, and I didn't know what it meant, until I became a nurse. But I remember carrying her around with that little bar in between everywhere because she wanted to get around and see things. I don't blame her. She was immobilized, wasn't she? If the kid is older, remember the tendons get really stiff and hard. So at this point, if they're over 2 years old, probably you're going to have to cut or make a hole in the tendon to make it more lax to be able to get those hips back into place. Club feet, crooked feet, basically foot and ankle. You do not need to know all the types. All you need to know is club feet. It's a crooked foot and ankle. And how do we treat it? Well, again, 2 to 3 weeks, we can correct, fractures, right? So as soon as we possibly can, they're going to be starting these serial casting. It's called the Ponseti method. And this is done weekly, not every month. Weekly, this parent has to bring this child in and get new casts put on, and slowly it corrects the deformity, because remember, their bones are softer, their tendons are softer, they mold easier, and just very easy, we put them back to where they should be. Now, as the kid grows, they need good follow-up, because we want to make sure the shoes are proper, that they're walking, they don't go inward or pigeon-toed. We want to make sure that still the feet and the ankles are working the way they should. So follow up as they get older. Now, I mentioned it quickly, osteogenesis imperfecta, and this is what you can call brittle bone disease. It is an inherited disorder. They don't know why it happens. There is no cure for it. And the treatment is basically supportive. So this child, you wouldn't be doing therapy for, because you could move their arms, their hands, pick them up even. You can crack ribs that easy just by picking them up. These children, I would pick up with a baby blanket and have a nurse on the other side pick up with me, so we're not touching the child, so we can change a bed underneath, because touching them and pulling them can really cause these brittle bones to occur. Now, I don't know if these children are known before birth, if they have what we call OI, osteogenesis imperfecta, but can you imagine if this child was a normal delivery with these brittle bones going through the birth canal? It could be the clavicles, could be the ribs, could be the cranium, all of them could have cracked. It's a very dangerous time for these children to make it through. But our goal is when they have these fractures to keep them in a position where we still can get this child up and into a wheelchair so they can keep them mobile, okay? These children are alert, okay? They are, I had this one kid who used to chase me around going to the cafeteria at the hospital, and he would always start yelling, beep, 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 and in his electric wheelchair, he'd be rolling down to get himself a soda, a treat, whatever, out of the cafeteria. So they are alert. There are sweet children, but they are really, the bone fractures, very painful. We do give biphosphonate therapy, calcium pills, vitamin Ds, but it's basically supportive. There's nothing really we can do. Nothing helps it either way. Late calf perth disease. This is an aseptic necrosis of the femoral head. So the head of the femur has some sort of infection, and if you look at the x-ray, you see white fuzz. Something's happening to the bone up there. Children 2 to 12 years old Common in the males, 4 to 8. These children, the problem with them is that there's somehow a disturbed circulation there, and it causes ischemic, and that causes the necrosis because there's no blood, no nutrition, it's going to die. So we don't know why all of a sudden these children will have a limp, be sore. They're not going to be able to maybe lift their leg up as much as they did. They don't really know if they were hit, fell down. They don't really know. Usually the pain, it's sort of like RA in the morning, or when you sit too long, when you get up, you're going to hear it. And as I said, when you see it, you're going to see that white fuzz there. Treatment, bed rest. So another immobile child going to be placed on bed rest, and the treatment is no weight bearing. Leave the leg alone, let it rest, and then NSAIDs for pain. Sometimes they'll put on some traction, like a Buck's traction, and sometimes that relieves the pressure on the head. But it does take some time, but they can come through this. Now let's look at some spinal curvatures of the wrong way. Kyphosis is literally the thoracic spine humpback. Simply that. It could be due to the osteodystrophy that can happen, with lack of vitamins. Lordosis is the lumbar spine curves in. So literally the child is going to lean backwards because it's all moved in like that. Scoliosis, this is the bone of the spine that, your NCLEX just loves, one of those. It's an S-shaped curve. And it literally, when it curves, if you can see the girl on the right, it pushes the lung on that side. So it compresses the lung field. So you can't breathe as well. So it can happen at birth or during childhood. You can see it occurring and becoming, more prominent. Usually you'll see it the most at that pre-adolescent growth spurt. Remember, 25% of their growth is during those 2 years. So that's when you see it. And what do we do for scoliosis? Well, as I said, there's a curve there. If it's 40% or less, we can treat it conservatively. We will put them in a brace 23 hours a day again, only offer bathing, and they'll be doing some physical therapy and exercises to strengthen their muscles. And most of the time, they'll put it back into, a more agreeable position so that the lungs can still breathe. Now, if it's more than 40 degrees, it's really pushing. Remember, that lung is being squished too. So there's a really good reason to do the surgery. They'll do either the Harrington or the Luque rods. The Harrington rods is the most common. They'll take and they'll attach these little areas and put a rod, a literal rod, on either side of the spine, and it will straighten up that spine as best it can. It won't be perfect, but it will be better than that 40-degree curve, and that will be the treatment for greater than 40 degrees. Bone infections, osteomyelitis. Sometimes, you just have this little pain in your toe, and all of a sudden now you have a fever and you see a red streak. So now you go to the doctor. And it could have been you stepped on something, didn't pay attention, and now it's all red and swollen. And now you've got, elevated white count, fever, chills. And what they'll do is an X-ray. And because of the fever, chills, and because of the elevated white count, the leukocytosis, they'll be doing a blood culture, making sure that this, and it's a staph infection, doesn't get, central in, more like sepsis. So sometimes, you catch it pretty quick, it's annoying. You see a little red, you don't get to the point of having the fever and whatnot. Usually that one we can clear up a little quicker. Now, it is a staph infection. It requires IV antibiotics. The antibiotic used for staph infections is vancomycin. Vancomycin is an aminoglycoside. Remember, peak levels, trough levels, worrying about hearing and kidney damage. So these children really need to be monitored for their levels and for their kidney values, because these children at home teach the parent that we are going to be monitoring how many times do they urinate. Is it the normal amount? If it's a younger child, we can count diapers. An older child, they're on bed rest. So they will be monitoring what urine's coming up on them. It can hurt, so we'll give them something for pain depending on the level. And again, these children are there for quite a while. It could be a couple months if they're on it. So nutrition, very important. These children need a high protein diet, which aids in bone healing, and some carbohydrates, that help too. And again, they are immobile. Give the kids something to do while they're on bed rest with a PICC line at home, because these children will be at home schooled. Now, we've mentioned cancer before, but we're going to mention 2 or 3 of them right now. And these are something to do with the muscles or the bones. Now, Ewing sarcoma is the second most common malignant bone tumor in children. It's rare for older kids over 30, but younger, that's when you see it. Any bone, fibula, tibula, ulnar, humerus, doesn't matter. This is a scapula, and you see it's big, it's enlarged. They do radiation, chemo, and if they can, some surgery to take care of it. And as long as we catch it before metastasis, like any other cancer, they'll do very well. Rhabdomyosarcoma is from the muscle, comes out of the gums, out of the nares, from the ear, and it also can get to the kidneys and the peritoneum, and the muscular tissue around there. This children, it is highly malignant. Most of the time it's metastasized, but if we catch it good enough, that radiation, chemo, and surgery can help. They will be on a prolonged chemotherapy because it is highly malignant, just to ensure remission. Now, JIA, juvenile idiopathic arthritis, formerly known as juvenile rheumatoid arthritis. It is in children. It does occur. We usually see all of a sudden the kid starts limping, complaining of stiffness in the morning. Same thing like an adult would. And you'll see this in children ages 1 to 3. Many times it takes a while to diagnose these children. So the morning stiffness, difficulty walking. I think uveitis would be nice if we saw that in all children. Big red eyes, something's going on. It's not Kawasaki, right? Because Kawasaki has those red eyes. It's going to be the JIA. Now, it's very difficult to diagnose juvenile idiopathic arthritis. It took me 10 years to be diagnosed with adult rheumatoid arthritis. 10 years. And I kept saying what I had, and they kept saying you don't. Finally, I had a physician who did this test that I had never heard of, and it came back so positive. He's like, oh my goodness, you are. I'm like, thanks for listening. So anyway, so I'm being treated now. That's all that matters. But you can see if I had a hard time getting diagnosed, can you imagine somebody who has no medical knowledge at all? Okay, very difficult. You could do all of the inflammatory factors. You can see ANA positive, rheumatoid positive, but it could be positive, it could be negative, depending on where you are. Are you in a type flare that you don't know you are or not? So we know there's no cure with it, but our goal is to preserve function, prevent those deformities, and try to decrease the amount of pain that you're having. Because when your finger, your arm, your knee, your shoulder don't work, it hurts, and you're moving, so you have to use these things. So it is uncomfortable. So this is done at home. NSAIDs are the drug of choice for these children. Corticosteroids are used for flares. Methotrexate is used, and then Humira, Enbrel. It could be an infusion, could be Remicade, any of those, depending on the child. because everybody is on a different treatment. There's not one set in stone. It depends on how do you respond. I think I'm on my 9th type of treatment right now. So that's how hard this is. What do we need to do? Physical therapy, occupational therapy. Why? Keep moving, keep moving. I've got a pool in my backyard. I swim as much as I can. Keep moving, keep those muscles going, force yourself to move, take an NSAID, relieve that pain, and use heat and exercise. Like I said, I hate heat. Put cold on me. That helps me. Whatever works for the child, work with the child, and let the child know what's going on, what they need to do. And children are so smart. They're starting to hurt, you give them a squeezy ball in the hand and they'll just start squeezing the ball because they know I hurt, let me take care of it. Kids are easily trained. It's adults who don't listen. The kids do. That's why I love working with them. Lupus is another autoimmune disease, but this one attacks the organs. RA attacks the joints and joint swelling. Lupus is organs. We usually see it with girls ages 10 to 19 from the African American, Asian, Hispanic tendencies. And we will see some of the triggers of this from hormone imbalance. Could be going through puberty when we first see it. Could be another immune disorder. It could be you took a drug that your body didn't like, could have caused it, infection, stress. And the one I wasn't really aware of was overexposure to sunlight. You have a child who, like me, I live in South Florida. You're going to be out in the sun. So limit their time and put sunscreens on them. You saw the picture, nice little butterfly rash, but it could look like this too. They're all different things, but you'll see them located in the chins. You're going to see sometimes when these kids are just being diagnosed, you might see the rash, you might not. It might be a seizure or pleurisy that figures maybe it's lupus. It doesn't have to be all of these things. You're just going to see something and say, well, it's nausea and vomiting, diarrhea and pain. It's nothing, it's just maybe a GI problem. And you keep, to the next, and all of a sudden, child's getting really forgetful. Oh, I think I saw a seizure. Now you're looking for other stuff. And it's usually the combination is when you finally say, okay, kid's got lupus. Goals of treatment is to keep the kid as possibly normal as possible. That is our goal. The compliance is the big deal, taking the medicines as they need and to minimize exasperations and teach them about sunscreen, putting it on. Now, Kirsten is 10 years old, sustained a fracture in the epiphyseal plate in her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider that what? What is an epiphyseal plate?
See.
The epiphyseal plate is a growth plate, remember? Growth plates, we worry about, which is another name, epiphyseal plate, growth plate. If they're not fixed right, it's going to affect the bone growth. It could get crooked or it was not going to grow the way it should. Okay, it's all about growth. Epiphyseal plate, we need to be concerned about the growth of whatever that bone is. Now we'll do neuromuscular, muscular dysfunction. When you think of neuromuscular, I think cerebral palsy. That's the first thing I think of. And cerebral palsy is a permanent disorder, and it affects the movement postures of these children so that they're not able to do some activities, decreased fine motor skills, decreased gross motor skills. And there's different sort of cerebral palsies, but we think of cerebral palsy, we think of spastic cerebral palsy, which is more of the ones where the muscles tighten up and spasm. And you'll see big muscles on some of these spastic children. And it's harder for them to do activities, even to write on a pad or even to feed themselves. So, cerebral palsy, there's all different levels here. You have from mild to severe. It could be due to some gross abnormalities in the brain, could have been due to something with the blood flow. Remember, I've talked several times about the younger infants and blood flow in the brain. If it's too much flow, there's chances of bleeding into the brain, and that can cause disabilities. Well, one is cerebral palsy. It could have been due to that low birth weight, or maybe an anoxic or hypoxic episode at birth. Many times, you'll have children, I've seen it, I can't even tell you how many times I've heard this. A child's trying to come out, baby's trying to be born, and they can't do a normal delivery, and they have to switch gears and get them into a C-section immediately. There could have been a hypoxic episode at that time. So a lot of those children, we do watch them for cerebral palsy. I mean, that would be one that we would know or have a suspicion. Now, if we don't know, that's why we do those developmental assessments. The kid's not lifting his head up. The kid's not a involuntary grasp. Those simple things, something's wrong. So we need to go and we search, and then we'll do those neurological examinations and imaging, and we'll do even testing to see, was it something that came, from the parents. So as I said, that spastic cerebral palsy is the one we think of, and that is described as hypertonicity, poor posture, and difficulty maintaining balance. Now, these children, my little Jonathan, when I was doing clinicals, for Fortis, for pediatrics, we went to this prescribed pediatric daycare, which I loved. Within it, they had speech, occupational, and physical therapy, top-notch place. My little Jonathan, little 7-year-old in a wheelchair, nonverbal, really severe spastic cerebral palsy, would see me, and he was my boyfriend, and he knew it. He'd look at me and he'd smile, and his arms would come up and he'd get so stiff. It's that spasticity that you think of, and he's smiling so hard, and he just wants me to come over to him. When we have that cerebral palsy like that, we can treat it with different things. And that's the next slide. So what would you see with cerebral palsy? Well, as I said, that delayed motor development, whether it's gross or fine, doesn't matter. You'd see those muscles not working the way they should. So abnormal motor performance. Many of them will never walk, and many do. You'll see them sitting differently or unable to sit up properly. Those reflexes are not going to be the same. So what is our goal for this child? What's my goal for Jonathan? Well, he's in a wheelchair. We can move him around. I mean, he does not have the ability yet to be able to push himself around or have an electric wheelchair yet, but they're working on it, and I'm sure he's going to get there. This little boy is more of a mild cerebral palsy. We can see the splints on his legs, which we do use a lot in cerebral palsy to get the good posture, of the muscles. This kid can get around, he can move, and that's what we want to do, and he's happy. So locomotion, somehow, how can they get around from point A to point B? Kids like to move. Communication, Jonathan is he's nonverbal, he doesn't talk, but he has a pad where he can express what he wants. He's doing school, he's, learning colors and shapes and things that years ago we didn't teach these children. He's learning, and it's, when he gets it right, you should see him smiling, and then he starts to shake because he's so excited. These children, we try to put them in with the quote normal children so we can have that socialization, and it does help. I mean, I've even seen him with some of the videos and games, sitting there clapping his hands, when he's supposed to within the videos, and these are great things. This kid has gone further than they've ever thought he would, and he's probably going to go even further than that. So as I said, ankle foot braces, we put those on and off. Sometimes if they're so spastic, we might do something to orthopedic to relieve those. Pharmacological agents. Jonathan was started on carbidopa levodopa. We use that for Parkinsonism, which is a spasticity too, right? And it has helped quite a bit of it. Botulism injections help that muscle to relax. They need good hygiene because a lot of them do have seizures. So they're on those anti-epileptic medications, which, you can have that, gums, reddened and thickened, and we need to take care of their teeth. And of course, physical occupational therapy, keep those muscles, moving and not contracted. So prognosis, these kids can have, most of them, 85% will be able to ambulate, which I think is really good. And this is doing all the physical therapy, braces and everything all the way up and getting them the strength to be able to do that. These kids are doing a lot more than they did 30 years ago when I first started to meet them. Their care management at home, make sure they have the parent has what they need. Do they have the equipment so that they're able to get the child up and out of bed, and to bathe them? Do they have the medications? Do they need whatever equipment to help them? Jonathan cannot eat. He doesn't have that ability. He chokes when you put things in his mouth. So he has a G tube, he has his pump, and he has the tubings and the feedings, and he has his medications. And, these families need all the support we can give them, and to show them where the resources are. So I said I was going to show you something that would put a child with decreased sensation in the lower extremities. And this is a neural tube deficit. Neural tube is your spinal column. And at the lower base of it, the lumbar area, the meninges and spinal cord don't close in, they're coming out. And it looks like that purple blob. And it's from a small to big one. They're all different sizes. You could call them a spinal bifida, you could call them a myelomeningocele. These children, when this comes out, just think of all the nerves that were stretched and probably broke, and the decreased sensations of the lower extremities. You will see a problem with urination. Do they feel it? Was that nerve hit? You will also see problems with constipation. So nursing priority is to monitor their bowel and their urinary functions to make sure it is moving. When this child's born, our goal is just a dry, sterile dressing, and we will keep them on their bellies. So it could be due to the mother or genetic. It could be the mom with, you have a mother with obesity, diabetes, and sometimes it's just a low vitamin level that can happen. We're supposed to take that folic acid before we become pregnant, which is supposed to decrease neural tube deficits. We learned that in pharmacology, and we're like, what's a neural tube deficit? Well, this is what it is. So what do we do for these children? We are going to have them with a dry, sterile dressing. We're going to keep them on their abdomen, be on a monitor, of course, because they're on their abdomen. And because of the possibility of multiple surgeries and maybe even straight calf every 4 hours for those without urinary function control, we're going to put them latex allergy at birth. Before we even touch them with latex, they are going to be latex allergy. In the past, we've had children that we didn't do it immediately and waited till they almost went anaphylactic before we did it. Now, isn't that silly? We know the possibilities there. Well, we do it now to make sure. So again, 0.4 milligrams of folic acid a day. Now, I've got a myelomeningocele story for you. So mommy came in, was standing next to her warmer with a baby with a big purple blob, just like you saw, and was crying, and nobody was in the room. And it was just me, and it wasn't my kid, but I couldn't leave a mom crying, could I? So I went up next to her and I says, Mom, what's the matter? She goes, well, I don't know if my baby's gonna live. I says, Mom, I'm sure that we're going to do everything we can to have your baby be the best he can be. I says, look at his face, isn't he beautiful? And his name was Manuel Louis, I'll never forget him. And I says, you look like a mother who's going to do such good things for her child and everything you need to do to help him. Says he may have some decreased sensation in his lower extremities, and you're going to have to do extra special care, but I know that you can do it. And then what I did is I said, sit down, you're going to hold your child right now. She said, I said, no, sit down, you're holding your child right now. And she sat there and I told her how to hold him and not hurt him. And she just looked at him and just sat there and cried and rocked with her baby. 14 years later, this kid did well, got him through surgery. Yes, he had decreased sensation, couldn't barely move his lower extremities. But 14 years later, this mother found me down in the emergency room and was pointing at me. And one of the clerks came and got me. This mother wants you. He says, Betty Boop, because they always called me Betty Boop, because you'll remember that name. And I go, yeah. She goes, this is Manuel Louis. You helped me take care of him when he was a newborn. She had a picture on her keychain that had me holding her baby 14 years before. And she said, I've been looking for you to thank you because you really helped. So just taking what, 5 minutes?
So
10 minutes?
awesome.
It was. When you hear that, it's just wonderful. Okay, spinal muscular atrophy. Now we're going to get into the dystrophies. I think this is the most horrible of all. This is the floppy infant syndrome, which means their muscles don't work. They never hold their head up, and it's progressive, and they usually die before the age of 2. So this child, never really moves. It's weak cry, cough, but this child will, die very soon. Now, the one muscular dystrophy that you're going to see again and again, they love Duchenne muscular dystrophy. This is the one that you'll see on HESEs, you'll see on your NCLEX, and it's the one that sort of represents what muscular dystrophy is for, the examination purposes. What this is an inherited disease, X-linked, and mom gives it to them, and it doesn't appear until about age 3. And what you start to see is a child waddling, starting to fall down, and then literally crawling up the legs, which is called Gower sign, to stand up like I do now. You know how you help yourself up? Well, you start to see this weakening, and it's a progressive muscle weakness and wasting. Once we see this muscle weakness and this shuffling and falling, they'll do an examination called an EMG, an electromyography, which literally looks at the nerves and the muscles and the stimulation of them. And they take these little probes and put it on your arms or your legs, and they put a stimulus, and it makes that muscle spasm. It hurts, okay? Remember, if we're doing it on a kid, make sure we're giving them something for pain. And if they're old enough to warn them, they're going to be uncomfortable when it's done, okay? But make sure they go to that procedure with something. And that's usually how they're going to diagnose it. Now, it gets progressive to the point where these children, now the muscles aren't working. Remember, these are muscles. And then they usually in the teenage area die from respiratory or cardiac failure. These are muscles, they just stop working. These children will end up in a wheelchair because they can't move. And as I said, what you're going to see, waddling gait, frequent falls, and then Gower sign, crawling up their body to stand up. Lordosis, remember the lower spine's going to curve. And then we're going to see these different looks of enlarged muscles in the thighs and the upper arms. It's just something it is. And then we're going to see them, their cognition is not going to be normal. It's going to be mild to moderate. And because they can't move and it's muscle wasting, there are going to be tendencies for obesity. So our goal now, it's muscle wasting. So we got to take care of the muscles, what we have. So physical therapy, keeping them moving, range of motion, bracings, making sure they do as much as they can. And then, of course, if this parent wants another child to do genetic testing to see what's the possibility of another one. Acquired Guillain-Barré syndrome. Guillain-Barré, it's an ascending infectious polyneuritis. It's viral. It's not a bacterial thing that goes on here. I've seen it usually after upper respiratory type infections, like 3 weeks before. And you see it in ages 4 to 10. And you'll start again seeing that weakness in the feet, because it starts with the feet and works up, ascending. And then you'll see it go to where the bladder is, then you see incontinence, whether they're not incontinent, that they're have been potty trained for a long time, even becoming constipated where it's not normal for them. And then it works up and it hits what nerve? The phrenic nerve. The phrenic nerve, what does that do? It controls your diaphragm and your breathing. So you stop breathing completely. So nursing priority. What are we monitoring the most? Respiratory, because that is something that, breathing, you're not breathing, nothing else really matters, okay? So it starts from the feet and becomes numbness going up. It goes to the bladder, incontinence, constipation, hits the phrenic nerve, you stop breathing. It's going to require intubation, probably a tracheostomy, because it usually lasts for a little bit of time. How do we treat Guillain-Barré? Well, the treatment, IVIG, intravenous immunoglobulins. They're saying maybe steroids, but it's not really been proven. They say IVIG is the treatment of most, and of course, a ventilator. These children will need to have respiratory support until they start breathing on their own. And as a nurse, you see a child with Guillain-Barré, and you see them go down and require the ventilator. And then all of a sudden one day you start seeing them taking breaths over the rate of the ventilator. And you're like, yes, he's coming back. He's coming back. And remember, they have their eyes, they use them, they answer yes and no's, and they're alert. So again, keep them stimulated, because this isn't a mobile kid again. So make sure that you take care of them. And I'm sure you will. Tetanus is cured by a simple little tetanus shot, every 10 years, but sometimes you're not vaccinated and you step on something dirty, and we have the tetani bacilla that goes right in, and now it starts the process of lockjaw. It has to do with muscle rigidity. Think about putting your neck real tight, okay? And keep it there, and then keep it there, and don't stop. It's so painful, and then it creates all of this swelling in the neck, and it causes swelling, and then respiratory problems, difficulty swallowing, and again, this one's going to require to be intubated. Now, this is a sick child. You are going to see a child is awake and alert. You're going to need to ventilate these children, because you got to take care of the spasming here. So you put them on really good muscle relaxants, usually paralytic agents. And they say, if we can get this child to keep alive for 4 days, they'll probably recover. But many don't make it to 4 days. So tetanus is a vaccine. And then we get the booster when we have any incidences in between. So tetanus toxoid or tetanus antitoxin should be given after exposures. Cleaning it, because it's soap and water, it doesn't have to be anything crazy. If we let it go too far, and of course it gets worse, then of course we're going to have to clean it with different things and antibiotic ointments, etc. But tetanus, we treat with tetanus toxoid. Again, sick kid in the ICU, wound care we're going to continue, and then those muscle relaxants. And whenever we do a muscle relaxant and a paralytic agent, we absolutely will sedate these children to make sure that they're not wide awake on a ventilator and can't move. Botulism. Now, in the culture here in South Florida, It is believed if an infant is constipated, you can give a little teaspoon of honey or Karo syrup and it will relieve the constipation. Well, it can cause botulism. We do not know if the honey was sterilized, how long the honey's been around. Same thing with Karo syrup. So it should not be used under any circumstances for infants, okay? Botulism causes weakness, speech problems, and it goes to progressive, life-threatening respiratory paralysis. This is all from giving the infant a little bit of honey because they're constipated. So how do we treat this botulism? IV botulism immunoglobulins. We are, of course, going to support their respiratory, and always any child who is supported with a respirator, always nutritional support. We are going to maintain nutrition for these children. Okay, spinal cord injuries. Let's go back to that 16-year-old boy whose head hit the knee of that third baseman, came in. So it is a result of a sports injury. Now, it could be due to other things. Could have been a car crash. At birth, we pull the neck, don't we, when we get these children out of the birth canal? It could be due to hyperextension, flexion of the neck, like sometimes in the car, you're pushed and your head snaps. Those can call your spinal cord injuries. Now, at the scene of the injury, now this child was medevaced. It was in a helicopter when it came to me. It landed upstairs on the roof. We had to go get it. And this child was on a backboard, had a big, hard collar on. He was even taped to the boards and everything. Came in, you know, to the trauma room. And my priority before anything is to protect that neck. So this child already had that right leg who was, you know, already pretty numb, and the left leg had minimal movement. So I'm scared. I'm really scared. So I was watching that. Now, of course, we're going to hook him up to a monitor his respirations, absolutely, vital signs, yes. But if I have no neck, you know, this kid will be paralyzed from the waist, you know, from maybe, you know, from the neck down, who knows? So it took a lot of people to take care of this kid, right? What we had to do, he had that angulated, not straight cervical spine. It was literally, you could see almost a triangle. It was that severe. I'm not exaggerating. We took him over to an MRI. I had to make sure that this child was transferred off of the backboard onto the MRI table on my call, and I took care of the neck as we moved. Okay, end of story. We had it done. He went to ICU, got the tongs, had his surgery. 2 weeks later, I went to see this boy, and he remembered me because I kept him calm. He had feeling in his lower legs. He had some decreased muscle tone. He was going to therapy, and a year later, he came to visit, and he was fine. He completely pulled through this, and it was all because of watching the neck. Everything else didn't matter. Well, it did, but without the neck, the outcome wouldn't have been where we wanted to be. So spinal cord injuries, proper immobilization. So a progressive infantile spinal muscular atrophy, which is called the floppy infant syndrome, and I won't make you suffer, it's Wording-Hoffmann's disease, it's C. I didn't want you to suffer on that one. So a lot of stories today. Who wants to win the cahoots? Is anybody here, or do I have all names today? I know.
I'm here.
All right. All right, there we go. I think there's 39 today, not as long as usual, just hitting the high points that you need to know. Remember, I'm doing my review at 5:30 today for exam number 3. Again, it will be recorded. You'll get all the recordings. And go to your calendars for the review on Friday and Saturday. Their links, their Zoom links, everything are on your calendar. So you don't have to go back to announcements. I made sure everybody has them on the calendar. Okay. Musculoskeletal neuromuscular dysfunction. It's week 9. Amazing. A multi-select. What is the priority for a nurse to assess following a cast application? Hmm. You have a broken bone, they fixed it, they put a cast on. What are you watching and what are you going to teach the parents and child to look for? Absolutely everything. So we want to know about the pulses, the pain. Is it too much or is it, about where it was? It makes a difference. Can you move it and can you feel it? All of those things are important. Many a cast I've had to cut windows in because of the pressure in there. What should the nurse monitor after a soft tissue injury? Big bruising, just a bruise, right? So we're going to check neurovascular signs. Vital sign is not going to do anything in a soft tissue injury. What we want to make sure is that the blood is still flowing distally to wherever that bruising, that soft tissue injury is, because we don't know how much of the blood supply has been occluded. A fracture that penetrates the skin is called what sort of fracture? I mean, there's many fractures and they're closed, right? So what would be the one that the skin comes through? And it's called a compound or open fracture. Green stick is still a closed fracture. It's cracked inside. It's a bunch of pieces. As I said, it could be all different things it's inside. The compound is the open one. And remember that one, you're worried about infection, IV antibiotics. What is priority nursing care for a child who fell off a second floor balcony? I've seen this more than once. Young children, 2 years old, 3-year-old, fallen off and somehow made it. Their children are amazing. Again, whenever you're talking injury, we're going to be talking about strict immobilization of that spine. The second thing is your neuro checks and checking pupils. And if you see one eye that's, dilated and the other one's not, remember that's your emergency. And Mary's on fire. Look at you. Principles of managing soft tissue injury include: you've got a sprain. You went up and you spiked that ball and you got the point and you landed right on the outside of your ankle and it went, and I can still feel it. It hurts. So first thing, rest it, ice it, compress it, and elevate it. That's absolutely the perfect thing to do. Put it up in the air like I do. Epiphyseal plate fractures in children may what? Again, what is an epiphyseal plate? So the epiphyseal plate, the other name is a growth plate. If you don't have it lined up and fixed correctly, it will disrupt the growth of the bones or cause a major deformity. Very important that they're set properly. What findings for a patient in skeletal traction indicate peripheral neurovascular impairment? So neurovascular signs is about blood flowing. If there's no pulse, that is a problem and it needs to be reported and corrected as soon as we can. How should the nurse care for the skeletal traction for a child with a fractured femur? So you're in that box traction. You have that rope that's down to the weights and it's pulling with that little boot. It's called bucks traction. It works beautifully. The big thing is to make sure those weights are free hanging, never to take that weight off because you might make those bones dislodge again and it's going to cause pain and spasms. And we do not want to do that. And Kim's now on fire. Look at you. When caring for a 9-year-old in bucks traction, what action by the nurse is correct? Again, bucks traction is usually used for a fractured femur. So we are going to distally check for neurovascular signs, capillary refill, pulses, etc. Very good. Good job. A multi-select. Which assessment indicates an infant has developmental dysplasia of the hip? I mean, that hip socket, that ball of that femur is not where it should be. It's up here somewhere. So we are going to see a positive ortolani, and of course, those skin folds are going to be crooked. Very good. Which statement by parents indicate more teaching is needed regarding their 2-month-old infant with club feet? What's the treatment? Well, it's that Ponseti serial casting is what we do. And we put it on as soon as possible, right? And then how often do we change it? Every week, all right? So the answer to this one is every month? No, the parent needs to know every week they need to come in. And then remember that infant will require follow-up until they're grown to make sure that those feet continue to grow properly. Good job. Multi-select. Osteogenesis imperfecta. Osteogenesis imperfecta is a genetic thing that occurs. It's also called brittle bone disease. And it's literally, all the bones break so quickly. It's a really sad thing to watch. It really is. I'm afraid to touch this poor child. When can osteogenesis imperfecta be the most life-threatening? And it usually right before birth. Remember, their bones are brittle. Do we know that they have this disease before they come out? Usually not, unless there's some familiar history. And of course, then a C-section will probably be planned. But even then, there's still some pulling and tugging that occurs. So right there at birth, you can fracture ribs, fracture clavicles, fracture the cranium, anything, and they break that easily. What is the pathologic cause of leg calf perth disease? Again, you see that white fuzzy stuff right there on the right side on the head of the femur. So it's ischemic aseptic necrosis, which means blood flow stops and then it starts killing or dying off the head of that femoral head. So how do we treat this? Bed rest, NSAIDs, and maybe some traction. And then usually the blood supply will start again. And if we've caught it good enough, the child will be okay. Kyphosis, what's that one? And that's what we call humpback. Very simply, it's the thoracic spine. Lordosis is described as. And I think that picture of that little girl really shows you, the depiction of what a child with it would look like. So that is the inward curve of the lumbar spine. Yes, very good. Scoliosis is. So when you think of scoliosis, think of that S. It's an S shape that is going on there. Very good. Adolescents with scoliosis that have a 25% curvature of the spine would need to do what? So you are going to have them in a brace 23 hours a day, and we're going to be doing exercise physical therapy for those children. Good job. Now Kim's back on fire and Mary took it over. What is osteomyelitis? So osteomyelitis is an infection of the bone. It's going to require bed rest and resting that bone. It's going to be IV antibiotics with a central line, usually a PICC line at home. And we really need to be monitoring, the lab values, especially kidney function, because these are the aminoglycosides. This is going to be vancomycin, one of those drugs. Juvenile rheumatoid arthritis is what? So basically JIA, JRA is inflammatory of the joint sacs, and it causes a lot of pain and stiffness and could go into a lot of deformities if we let it keep going. Goals for JIA include what? So we want to reduce the pain, reduce the swelling, and keep that function going on there for sure. Systemic lupus erythematosus is. So it's an autoimmune disease. Basic, that's all it is. You have JIA, which attacks joints, and lupus, which attacks the organs. A multi-select. What can help a child with lupus erythematosus prevent exacerbations? So you want to have sunscreen on them and decrease the amount of sun because that can cause flares in these children. And these children will get prophylactic treatment for things like dental work. And the prophylactic is not just antibiotic, it's also steroids, because steroids is something that decreases that inflammation that will be going on. What organs can lupus affect? Everything, anything, doesn't matter. Has no favorites. What is cerebral palsy? And cerebral palsy is all about muscle coordination and body movements and posturing. That's all about cerebral palsy when you talk about it. A myelomeningocele. So myelomeningocele is that big purple blob at the back that you'll see at birth. And it's a hernia of the spinal cord and the meninges. And it pulls those muscles, those nerves. That's why there are some sensation delays, in the lower extremities and even, a lot of non-movement because it's basically broken the connections there. Infants with myelomeningocele demonstrate what? So it's motor and sensory. Sometimes they can feel a little bit, sometimes not. Sometimes they can move a little bit, and sometimes they cannot. It all depends on the child and how much of a myelomeningocele that was there. Due to decreased motor and sensations of the lower extremity, what must the nurse monitor closely in a child with a myelomeningocele? In fact, it's your priority to monitor this. And it's for urinary retention. Remember, those muscles, those nerves are stretched, and we don't know if that bladder is got a nerve to it to tell that baby, I need to void. So you need to be monitoring urinary output. And many of these children end up on every 4 to 6 hour urinary straight catheterizations. So urine, we want to make sure we're monitoring that. And also bowel function is the other one, but urinary first. A key feature of Duchenne muscular dystrophy is so this is progressive muscle wasting. It starts with the kids that are 3 years old, and you start it with their falling down and starting their muscles becoming weak, and ends up with the teenagers where their lungs, fail, and that's why they die. Muscle wasting. One of the procedures that a child with possible Duchenne's may need to diagnose their condition is called what? And it's called an EMG. Very good. Remember, they hurt. Remember, you should medicate these children because of that. How is Duchenne muscular dystrophy inherited? Where does it come from? And it's an X linked. It comes from mommy, okay? The female is the X-linked that, passes on the Duchenne's. And Mary's back on fire. In caring for a patient with Guillain-Barré, the priority concern is what? What are you going to be worried about? Got a child, diagnosed. It's absolutely airway. Remember, phrenic nerve is a nerve. It does control lungs and breathing. These children, are going to end up on a ventilator. For a patient suffering with Guillain-Barré, they would complain of weakness. That was what? So it starts from the feet and works up. It's called ascending. It has nothing to do with the time of the day. It has to do with starts with the feet, works up. And then you could see them, the shuffling and weakness and numbness of the feet. And then you're going to see them incontinent and constipated. And then you're going to see the respiratory stop working because the nerve doesn't work no more. Multi-select. Treatment for Guillain-Barré include what? And it's IVIG and respiratory support. Remember, it is viral. It's nothing that can be treated with an antibiotic. So it's basically supportive. Support those lungs on a ventilator and then give them the IVIG. And that's all we really can do. Maybe steroids, but even that's not confirmed yet. It does go back the other way though. What type of cerebral palsy causes hypertonicity and poor fine motor skills? Or poor gross motor skills? It's called spastic, okay? Just think spastic. Just think of my Jonathan. He just got so spastic when he wanted to give me my hug. And he'd be smiling so big. I miss my little Jonathan. I have to go take a visit to go see him. What priority action should a nurse take to a patient with suspected spinal cord injury? Priority action. Patient, suspected spinal cord injury. Again, immobilize that spine. Good job, guys. You made me happy. You should get a tetanus shot every how many years? And a booster in between if you have an issue. And it's every 10 years. It used to be 5 years, but now it's 10 years. And they're also given diphtheria booster with it also. Mary's on fire. What is a symptom of tetanus? Tetanus, stepped on something, punctured your foot. And it's lockjaw. Remember, everything, the muscles tighten up, that it becomes a respiratory depression. Tetanus toxoid, immunoglobulins is what we're going to be given, and cleaning that wound and respiratory support on these children. Many of these children do not make it just from stepping on a nail. Most common causes of spinal cord injuries are, last question. It's motor vehicle, driving, sports, absolutely. Let's go with it. Number 3, LP. Okay, number 2, Kim. Good job, Kim. Number 1, whoop, 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 whoop. Mary J. Number 4, AR and CW. Good job, guys. What I'd like you to do is please sign your attestations, make sure that they get done. so I don't have to bother you, send you nasty messages. No, I don't send nasty messages. Anyway, any questions? I'll be doing my review at 5:30. I will be recording it. It'll be posted on my YouTube page. Do you know there was 685 views of my last exam review? And most of them were for at least 30 minutes. At least 30 minutes.
That's because we tell everybody how great
Yeah.
Yes, you do great reviews.
Yes, you do great reviews. Yes, I agree.
Thank you. Thank you. You want to listen, you want to work hard, you want to work hard, you can do well. So make me proud. Good job, guys. Make me proud. I'll see you later.
Bye.
I'll see you later.
Thanks, Bogart.
You're very welcome.
Bye-bye.
Bye, Miss Mary. Bye, Miss Mary.